The immediate experience that caused me to be interested in healthcare was the death of my father from an infection he acquired in a hospital. It wasn't until I think it was about 6 weeks after my father died, that in fact this very same New Yorker ran a piece by Atul Gawande in which he talked about the 100,000 Americans who die every year from hospital-acquired infections and how most of them are preventable and readily preventable. He talked about a doctor who'd run around the country trying to get hospitals to adopt very simple protocols for eliminating most, not all of these infections. And I think reading that piece, something inside me sort of snapped. Because when you've been in the hospital with a loved one, and many of us I'm sure have or have been in hospitals ourselves, you realize how different healthcare is from everything else. Mm-hmm. And what a lot of this book is about is, for most of those things, we just say, well, it's healthcare, it's different. As a society, as individuals, we give it a pass. So that we accept that if you have a loved one in a hospital, some member of the family should try to be there all the time. That's crazy. It's true, but it's crazy. I can tell you that even apart from what happened to my father, while he was in the hospital, he was 3 times taken for procedures meant for other patients. And as everyone in here knows, that story is not limited to my father. And so I think what happened is the combination of having gone through this personal tragedy, realizing how common it was, and then being a businessman caused me to say that. That seems like an extreme reaction, perhaps. But it caused me to say, wait a minute. How is this possible in this day and age, and how are we so accepting of it?
Let's break that down a little bit, because this is one of the most interesting parts of the book. You talk about what you call island thinking, that for some reason, whenever we think about healthcare, we abandon all of the assumptions and values and beliefs we have for everything else in the economy, and we assume the world is totally different. And I want to kind of go down the list of the ways in which somehow we become different people when we talk about healthcare.
Well, it's interesting, and our assumptions about healthcare are that it's fundamentally different from everything else on earth. And so that the rules and disciplines and accountability we use don't apply. And we say things that sound so sensible, and I talk about the island of healthcare as where the thinking about healthcare occurs. We say things that sound so sensible, and then you apply it to anything else and think, wait, that makes no sense. So in healthcare, we talk about costs. We never talk about prices, as if somehow these things are externally generated as opposed to somebody setting a price. Right? We recognize in everything else that everything that's a cost is really someone's price, the price of their labor, the price of their capital. But you will almost never hear anyone refer to healthcare prices, interestingly, except for pharmaceuticals. Yeah. So that's one, and that language means a lot. Another one is we tend to confuse healthcare with health insurance. Health insurance is a method of finance, and healthcare is what it's financing. They are very different. You heard politicians, particularly in the debate over the Affordable Care Act, talk about people who had no health care when they meant had no health insurance. It matters a lot because, in fact, there was almost no one in the country really without health care, but without access to some of the health care that only health insurance makes possible.
But that's on a slightly different. I wanted to just take a little step back from that and talk. But there's something more fundamental here, right? So with in no other area of the economy or our lives do we take it for granted that any complex economic system is best run by a large group of people in Washington, D.C., right? With a single payer and with healthcare, we reverse that and we say, actually, no, we don't believe at all in any kind of market mechanism. We want people in Washington, a small group of people, to make every decision for us and set every price.
Well, I think what's interesting, and I think, again, you saw a lot of it in the political debate a couple years ago, is this assumption that in intention, when it works its way through a bureaucracy, actually leads to a policy that gives you what you want. So in healthcare, you see people say all the time, well, we should limit the cost of doctors, or we should limit the cost of drugs, as if there's a centralized way to actually do that effectively. And I know a lot of people think other countries are successfully doing it. I'll come back to that another time. But you're right. We think, I'll give you another example. In healthcare, all of us say technology is driving up the cost of care. We're all carrying cell phones. They have about the computational power of a computer 50 years ago that 10 people on Earth could afford. And we walk around with these cell phones in our pockets and say, technology is driving up the cost of healthcare. And of course it's not. What's driving up the cost of healthcare is the system is incented for expensive technology.
Wait, has there ever been a case in another industry where it could be said that technology drives up the price?
Yes. There's one other very important one, and it's a single-payer industry, defense. You know, no one ever thinks of defense as a single-payer industry, but of course it is. And of course it's one in which technology is endlessly driving up prices.
But if we accept industries that are run and paid for by the government, is there ever, I'm sort of curious for a moment, is there ever an instance where people run around and say,
well, no, because I think what most people expect from other industries is that when a technology is more expensive, an iPhone costs more than a BlackBerry, it's because it's providing additional value that justifies the additional price. In healthcare, what we say is that technology itself is pushing up the cost of care, not changing the results, not necessarily giving us greater value, but driving up the cost of care. And in some limited sense, it's right. It is driving it up, but because we have a system that encourages us to take in more expensive technology.
But it's weird, though. It's such a fascinating thing because all of the expectations and the language and the assumptions that we use in every other aspect of our lives are violated in this instance, right? It's exactly, this is what the first thing that so drew me to your analysis, which was, why are we so weird on this subject?
Well, I think there are good reasons we're weird, in fairness. I think one is emotional and deep, right, which is a lot of the issues about healthcare are about mortality of ourselves and our loved ones. Very few of us face big healthcare decisions that aren't very emotional. And we like the idea of being cared for. I mean, we are people who used to have shamans and witch doctors and all the rest. A very large part of the service that healthcare gives us is a sense of being cared for. It's why placebos are so powerful. But I think there's also a historical reason, which is up until the 20th century, there wasn't very much healthcare that actually did any good. And our experience of healthcare interventions at the beginning were big, expensive things that for the first time in our history actually did something positive. But they were out of the reach of most people. Mm-hmm. And most of our thinking about healthcare, how to finance it, how to build assistance to people to support it and pay for it, comes out of that sort of industrialized age of medicine that ensued. And very little of it has anything to do with the way healthcare actually works today.
Yeah. The last one, and then I want to turn to the question of cost more, but the last weird assumption is that you sort of touch on, and this I think goes to the heart of your argument, has to do with our kind of our uncritical acceptance of the notion of insurance as the appropriate tool for solving the problem. So there is no other aspect of our life when faced with some complicated issue, we say, oh, the answer to that would be to have insurance. So all of us, at some point in our life, would like to buy an apartment in New York. If we were to apply the healthcare thinking to that, we would say, well, then we should all, from the time we get out of college, start paying into apartment insurance. And then when a certain time comes, when you don't know when it is, we'll be able to get a payout from the insurance company to buy our apartment.
Yeah, right? it is very weird, but it really is about how healthcare has evolved beyond the early assumptions of health insurance, which was hospitalization insurance. I mean, we all have auto insurance. We don't get our tune-ups by applying to our auto insurer. We have homeowners insurance, but I mean, what I would suggest is if you think about what the market for homeowners insurance would look like if you could file a claim when your furniture was worn or out of style. That's what we've done in healthcare. And it all relates to what's probably the biggest element of island thinking, which is, and we're engaging in it right now, which is that there's this thing called healthcare, right? I mean, in no other good or service do we include absolute urgent emergencies and tune-ups as the same good. Yeah. You know, what's interesting is we all think there should be one way of paying for everything in healthcare. Well, that's a big problem. It's incredibly inefficient, incredibly expensive, and incredibly distortive, and completely different the way we think of everything else. You don't think to yourself, there's only one, to use your metaphor, there's only one way to pay for the down payment on my apartment, the loan on my apartment, the utilities in my apartment. That would be absurd. And the reason we don't do it is because insurance is the most distortive, complex, bureaucratic, and just expensive way of, and costly way of paying for anything.
let's talk about cost for a moment, because this is the other thing in your book that stunned me, and that is that I realized that none of us have an accurate sense of how much this is costing us. So walk me through. You have a wonderful example of someone who works for your company, where you walk through and you actually tell us precisely what her health care costs her and will cost her over the course of her life. Walk me through the math.
Well, I start the book with Becky, who actually was a real person, although that was not her real name in our company, and was interviewed for the book. And I look at what healthcare is taking out of her income today and what it's likely to over her lifetime. So Becky, 23 years old when we started this project, entry level. We paid reasonably well for somebody. I think it's really her second job. We paid her $35,000 a year.
Where did she live? Iowa? Just kidding. Go on.
You know,
What did you make by chance last year? No, I'm teasing.
I have to supervise Becky, so obviously that means I have to be paid a little more than she is. But I think let's imagine this is a conversation about America and not just New York, where the median household income is $50,000. What's interesting about Becky is that as far as Becky knows, she's spending a couple $1,000s a year for healthcare. Right? She's spending roughly that on her share of insurance premiums. And maybe she's got a little out of pocket, maybe she doesn't. She's completely healthy, classic 23-year-old. In fact, Becky's contributing around $11,000 into our healthcare system this year. She doesn't know it. Most of it she doesn't see. And if you look at Becky over her whole life.
Wait, let's slow down for a second. Tell me where the 11 grand, so she's making 35.
Yeah.
And the total contributions made on behalf of Becky to healthcare.
Roughly $11,000.
So where does that come from?
So
break it down.
The cost of her insurance, of which she pays $2,000, is in fact $8,000. We're paying $6,000. And I think one of the biggest illusions in healthcare is that we're paying $6,000. We're of course paying nothing, right? Becky's paying all of it.
Wait, you're getting ahead of me here.
Go ahead.
Becky pays $2 grand out of pocket.
$2,000 out of her paycheck.
Out of her paycheck.
Pre-tax.
You, on her employer, pay $6,000.
Correct.
So we're at $8,000.
Right.
Okay, but that's only part of the cost.
Correct.
Let's go through the other costs.
Sure. Becky pays Part A Medicare tax.
Okay.
We pay Part A Medicare tax.
What does that come to?
And together,
roughly?
that's about 1.8% of her income. So, it's going to be roughly $600.
Okay.
Becky pays federal taxes and state taxes.
Yeah.
Roughly 20% of our current federal tax bill goes to subsidize Medicare, pay for Medicaid. What I didn't include in there, in the book, and I think if I were writing it today I would, is if you throw in VA healthcare, defense healthcare, Indian reservation healthcare, et cetera, the miscellaneous now is up to $300 billion, almost as large as Medicaid at $500 billion. But I didn't count that.
Let's have fun with this. Let's count this. So we've got $2 grand for Becky, $6,000 from you. How much of her taxes do you think can be reasonably called healthcare taxes?
Well,
if she's paying 15
roughly
grand?
20% of her federal tax. So on that kind of income, you're probably looking at $500.
Okay.
Is going into healthcare. I didn't count the fact that she was in New York State and New York City. So roughly 10% of, on average in this country, your state taxes are going into healthcare. For her, that's going to be very little at that income. Mm-hmm. And her deductible, which is about $500, I assume that she would bear.
So when we total all that up, all of the money that is set aside for Becky every year, how much? You saying 11?
It's not set aside for Becky. Is the point? It's what Becky is contributing into the whole.
No, yeah, but I mean, of the pool of money that is set aside for Becky, how much of that is going?
It rounds to $11 grand.
11 grand. Okay.
Of call it roughly, and I didn't include Social Security in this because it adds the calculation. But figure Becky costs us around $45,000.
Okay.
Roughly $11,000 of her cost of compensation is being paid by us and her into healthcare. So, day one, she's at close to a quarter of her real compensation is going for healthcare. Becky's earning $35,000 a year.
Yeah. Now let's do the math over the course of Becky's working career. What's that going to come to?
So, let's assume a couple things about Becky. You have to make assumptions in any of this. Let's assume that Becky's the breadwinner, gets married at 30, has a couple kids. I had her husband leave her at 65 so that she didn't have to pay 2 Medicare premiums. She'll be grateful for it.
That's right.
I also assumed a couple very important things about Becky. One is that she never gets rich. So she earns a nice middle-class living, grows 3% a year. By the time she retires at 65, she's earning $100,000 a year. And I assume that she never gets sick. She just pays her deductible and the sort of normal out-of-pocket people are paying. So if, starting when I did my analysis, and obviously it's no longer true since I did the analysis, I think it's 7 months ago, the cost of care in this country went up by exactly 0 between now and Becky's death at 80. Becky will pour into our healthcare system about $1.1 million.
Okay.
Somewhere between 1.1 and 1.2. Now let's say the Affordable Care Act works so that we just hit the numbers that the administration say are going to be the lowered rates of growth for the next 10 years. So at those lowered rates of growth, but north of 0, Becky will put in $1.9 million. If Becky does have a working spouse, to make it completely fair, but the working spouse doesn't have to pay for health insurance because Becky is, they're looking at $2.5 million. Now, the point of Becky is that one of the foundations of our healthcare system, and it's not just true here, but it's especially true here, is the only way to keep it going is for nobody to know. It's all built on this view, which Becky has. I mean, I interview her in the book, that if someone else isn't paying for my care, I'm in trouble. I can't possibly afford it. We literally have 100% of the population thinking someone else is paying for their care. And that is a fundamental illusion. And when you step away from that illusion and start saying to yourself, you know, most families could pay their health care bill on $1.1 million.
Their total lifetime health care bill. Yeah.
Easily. In fact, when you look at just the cost of administration and all the rest, it's $1,000 a household that just goes into administration of the system a year.
Yeah.
Right? That's enough to pay for most families' health care costs.
This fascinates me. That number is so outlandish that I would imagine if you took 1,000 Americans at random and asked them to estimate the total amount of money that was being taken out of their pool for healthcare over the course of their lifetime, nobody would come within an order of magnitude of that number.
Well, we have 120 people here. Even having told you, how many would have guessed that we were talking about $1 million over the lifetime for someone?
More than we were talking about 2.5 for
potentially
her,
2.5.
For no, it's a and here's the other thing. How much of that? So even before we get to the question of what you want to do to fix the system, I'm just curious about if we were completely honest with people about what their healthcare cost, how strong a motivation would that be for true reform of the system?
Well, I think it's about to be enormous reform, right? Because at some point, there's no way to hide all this, right? Part A is a small but important example, right? Part A, like Social Security, was always presented as kind of a segregated fund, right? We're really doing it to ensure that there's money available for hospitalization. So Part A, like Social Security, applied only to a certain amount of your earned income, and that went into the fund. And there's trustees who issue the longest imaginable report on how sustainable the fund is. It's all complete accounting fiction, right? When Part A has a surplus one year, they lend it to the government spends it on everything else. When it has a deficit, the government complete accounting fiction. Part A now covers all of your income, right? It covers your earned income, your unearned income, your investment income. It's just an income tax. If tomorrow we turned around and said to people, we're not going to raise your income taxes. However, we're going to set up a special national defense fund. We're going to tax everybody. We're going to ask you to contribute 5% of your income. It's legally required. But don't think of it as a tax increase. We'd never get away with it.
Yeah.
So a lot of what's happened in healthcare is and there's an endless number of analysts who seriously talk about how solvent Part A is, as if it's an actual thing, as opposed to an accounting fiction. There's a lot of that in healthcare. There's a lot of misdirection. And I think, in fact, if you said to people, here's what you're putting into the system over your lifetime, the shock would be revolutionary and the impact would be revolutionary.
You told me once that you thought that it would be really fun if employers were required to put on your monthly paycheck how much of your money was going to healthcare. You didn't ever do that at your company, did you?
Well, it was my idea of fun. I didn't mean it would be everybody's idea of fun. But
it was fun was in quotations at this point, but
no. But I think one of the things we see in politics, and I see it on both sides. I don't see any difference between the two parties on this, and I know how passionately people feel about their political identifications. But the major thing both sides have in common is for you not to know that as it relates to healthcare. Now, there's an intellectual justification for it. It's worth pointing out. It's not just about money and not just about politics. There's a belief, and it's a very important belief into how healthcare works, that if you know that if you're spending your own money and you know the price of anything, you are less likely to get care. So if you talk to what I would call the island experts who are subtle about this and sophisticated, what they'll say is, look, if you put in $1 million over your lifetime and you use only $500,000 of care, it was still worth it for you so that putting off that colonoscopy was not something you did for financial reasons. In other words, what we believe in healthcare is that the financial reason should always be stripped out. I understand the thinking. The problem is when it's taken to its extreme, you have what we have now, where you've had 10 years of basically flat wages in this country and massive increase in healthcare costs paid by the employers instead of wages. I've experienced this directly in my company. I mean, I can literally see this as this year was the first year in 4 years our premium increases were less than 10%. They were 9%. And if you don't believe when we sit down and say, what's the pool of money we have available for raises and bonuses, how much of it went for healthcare, then you've never run a barrel. Yeah. But every American company is dealing with this, and so every employee is dealing with it, whether they know it or not.
Yeah. Let's talk about the next part of your book that I was really taken by, which was this whole thing about prices. I mean, it really is at the core of your argument that you can't have, that no marketplace functions properly unless prices are real, right? So I know what the price of something is, and what the price of something is represents a true something tangible.
Right.
Well, that's not the right word, but let's talk a little bit about prices. You gave the example when you said your mother got a bill for your father's hospital stay, which was what again?
It was $650,000. It might have been more if they hadn't killed him. I don't know. I couldn't quite work out the details of it.
And what did that number mean?
Nothing. It's actually worth spending a moment thinking about that bill and what it meant, because bills are a very important communication tool between somebody who provides a service and the payer. A lot is in that bill. We all know healthcare bills are unreadable. They're intentionally unreadable. You're not the customer, number one. They don't want you to understand it, number two. And number three, you're supposed to feel grateful. You get a lot of your bills from an insurer. They know how to write English. They're not writing English because they don't want you to understand. They just want you to appreciate that you have health insurance. It's not an accident, right? And they get more and more incomprehensible, not less. But the hospital bill, I think, just on a second on that, there is nothing in those prices that are about anything. No one's paying them. Medicare doesn't even pay on the basis of those prices. Medicare pays on the basis of what are known DRGs. So their customer, Medicare, who paid 99.9% of the bill, paid a fixed rate having absolutely nothing to do with those prices.
As you point out, if that number was real, how long was your father in the hospital?
5 weeks.
For $600,000, you could have taken a room at the Plaza, hired three of the greatest specialists in the history of the world, flown them in first class from wherever they lived, bought 5, and then had all the meals sent up from downstairs, right? And come in under $600,000.
Easily, actually. I didn't quite go as far as you did because I'm not as imaginative as you are. All I did was, and I think I put him at the Four Seasons, but just because it was closer to home. This is not an endorsement of. But I think I put him at the Four Seasons, booked him a nice room, leased about $1 million of hospital equipment, gave him round-the-clock nurses, had, I don't remember the 3 best physicians, but I had a doctor spend 2 hours a day with him, which is about an hour and 50 minutes more than they spend in the hospital with you. You don't get individual round-the-clock nursing in the hospital. And I put food and some other things in. I got to $150,000. That's for a now admittedly I didn't pay for blood or the Four Seasons doesn't charge you extra for television, so I hadn't paid for that. But the point is that the prices mean nothing. Not that it's a bad deal, it's an irrelevant deal. That bill was presented to nobody. And what's important about the point...
Wait, so what, this is a crucial thing. What's going through there? Somebody at that insurance agency is going through this incredibly elaborate charade of printing up this phony number that has no basis in reality and putting it in the mail and sending it to you. What do they imagine you're doing when you read it?
Well, they imagine, I think, I could tell you what's at the bottom of the bill. It's, the cost of the service is $650,000, your share $990. So grateful.
Yeah.
You're supposed to be grateful. My mother didn't pay the $990.
This reminds me of what I did when I was in college. When I would bring a bottle of wine to someone's party, I used to take a felt tip marker and add a 0 to the price. So it'd be like, $7.50, and I would make it $75. This is essentially the game that's being...
Well, except they're adding more than 1 0, but I think other than that, it's the same.
But I was in a sense preparing myself for a career in the healthcare industry, in the health insurance industry by...
But I think it's not just of academic interest, right? Prices are the circulatory system of the economy. And it's the lack of prices that cause terrible decisions to be made in healthcare. I'll give you one example. I'm sure many of you have heard that one of the problems with the system is the most expensive type of care is emergency room care.
Oh, I love
It's a big issue in policy, right? And in fact, it's one of the big arguments for the Affordable Care Act, is rather than people go to the emergency room, it'd be better if they went to physicians and all the rest. I cannot believe that anyone who has ever made the statement, emergency room care is the most expensive form of care, has ever been to an actual emergency room. What is expensive relative to any other form of care? Yeah. My sister was an emergency room doc. She worked on salary, right? There's no bonuses or overtime. It's not the art. It's not the Grand Central waiting areas. All the equipment is shared. Most of it is shared with other parts of the hospital. But here's what happens. If you're a hospital...
Wait, it's more than that. It's like if I take a random group of people and make them wait for 19 hours to see a doctor, that's an awfully efficient way of using doctor's services.
Incredible, right? Of all services.
How is this expensive?
No, it's the opposite. It's by far the cheapest form of
You
care.
come in, no matter how sick you are, I make you just sit there until you give up or die or whatever. This is somehow expensive?
I just want I want to make clear that's not my plan.
I know. But this is, I'd say, my favorite part of the book was when you do that little thing on the ER, and I was like, oh my God, I have accepted this notion for years, and I have walked by ERs in my life and said, oh my goodness, it's the Taj Mahal in there, it's costing so much.
But the scary thing about it, I mean, as bad as it is for us to think that way, and even as bad as it is for policymakers to think that way, and they do, what's worse is the number of hospital administrators who think that way. And here's where it gets very pernicious, right? So if you're a hospital, it makes tons of sense to say my emergency room costs me a fortune. It's where a lot of your Medicaid patients come in. It's where a lot of your charity care comes in. The bigger those numbers are, the easier it is for you to lobby the state legislature and the local city council for protections. It's good for that number to be big. It's not to say that some hospitals don't bear an unusual burden of people who don't pay, but it is to say that there's a reason when you leave the Holland Tunnel, there's a sign that says, here's how many minutes wait you have in the emergency room at Bayonne. Because they want to attract that patient. Their advantage, trust me, this is the most expensive form of care, and it was a money loser for a hospital. They're not advertising for you to drop by the emergency room. And that sign's not intended for people in cardiac arrest who just so happen to be driving through the Holland Tunnel, right? That's for people seeking primary care. But what's important is the distortion. Is that we make decisions as a country, and even hospitals do in terms of allocating resources, on the basis of a fiction. And if you've ever run a business, or better yet, if you've ever been a customer, having prices that have absolutely no reality to what somebody pays, what something costs, at some point just means we can't figure out what's happening, and that's a big part of cost in our system.
Yeah. Now I want to talk briefly about, as a segue into your ideas about fixing this, about going rogue. You have, on occasion, experimented with going rogue on this, right? This shopping for...
Well, some of these weren't experiments. They were real-life realities of having lost health insurance. And
what about talk about that when you shopped for an MRI that one time,
well,
which I love.
The book does mention that my sister-in-law, who's not an American citizen, came to the U.S. and had a big swelling in her knee, and we wanted to get an MRI to see what the deal was. And our physician sent us to his MRI clinic, which wanted $1,200. And my wife...
Before we go any further, can we point out that this is a classic example of what we're talking about? That's an absurd price.
Well,
right?
If you think of what an MRI is, I mean, an MRI is the same business as owning an airplane, right? Which is, if it sits vacant, you're losing money. Right? It's one of the ironies about our saying technology is driving up costs in healthcare, because in fact technology should be doing to providers what that type of fixed cost does in everything else, which is create enormous competitive pressure to attract customers, which means cutting prices. In every other business where there's big fixed costs like that, you have guys competing on price, except in healthcare. So this is $1,200 for a 20-year technology, a machine that undoubtedly had been amortized over 10 years and required some guy earning, $65,000 a year to sit there for 15 minutes.
So it's, yeah.
That's it, right? That's and a little bit of electricity.
$100 a minute.
And it's funny, when I first wrote that, someone wrote in and said, you don't know about, or you're not talking about the charge that you have to pay every time you use an MRI to GE or Siemens or whoever made it. But of course, those charges can only exist in uncompetitive markets. They existed when Xerox had a monopoly forever. Right now, nobody pays every time you make a photocopy. You used to. So my wife, not wanting to spend $1,200 on her only sister,
naturally, I mean,
spent a day calling around other MRI clinics, and she's fairly blunt. Best offer I have is $1,000. If you beat it, we'll come in. I think at some point shame took over, and at $250 cash and 4 o'clock tomorrow, we said yes.
Yeah.
I think she experienced more than I did. I think she wanted to see if someone would pay us to do the MRI. but that story is often confused by people who hate the idea of consumers being involved in healthcare. They say, oh, great, I got hit by a bus, and now I have to negotiate. The key thing to understand about healthcare is there's no crazy Eddie of healthcare. It's a New York reference, as you all know. There's nobody out there saying, I'm practically giving MRIs away. Because what happens when we're the consumer isn't that we go out and do what my wife did. We did that only because she was a foreigner and had no health insurance. What happens when you're a consumer is the providers chase you. Walmart wasn't created because an angry mob, marched on Neiman Marcus and said, we demand lower prices, right? What happened is some guy said, I know how I'm going to become a billionaire. I'm going to give ridiculously low prices. That hasn't happened in healthcare because we're not the customer. And when we are the customer, suddenly you realize that healthcare is an industry that should have been impossible to maintain, much less raise prices, because it's so technologically oriented.
Yeah, what's amazing about that story is that it's a story. I mean, if I were to say to you, I'm going to tell you this fascinating story, and you're all going to say, oh my God, and this story consists of someone shopping for the lowest price, you would look at me like I was crazy. It's only in the context of healthcare that we somehow think, good Lord, she got them down to $250 for something that, by the way, should probably be $30. Right?
We have no way of knowing because interestingly, in MRIs now, a competitive market was developing before the Affordable Care Act. And in fact, in a lot of preventive care, we were starting to see competitive markets develop. I know many of you may be aware of the Minute Clinics and the other drugstore. All it was about doing tests for people who didn't want to claim under insurance, didn't want to pay under insurance, that were bearing big deductibles anyway. And prices were coming down very, very rapidly. Right? What did the Affordable Care Act say? Affordable Care Act said all that stuff must be covered by insurance and there must be no deductible. So goodbye competitive market, right? Goodbye low-price preventive care. Goodbye low-price contraceptions, by the way, for the exact same reason.
Yeah.
So, it's one of it's a trade-off we've made, I think, without being conscious of it, which is so that we don't ever have to know how much we pay for something. We pay a lot more for it. We just don't recognize all the hands in all our pockets.
I wanted to, before we get to your ideas about, your global ideas about fixing, I want to pursue the going rogue. Because my first thought reading this book was, wait a minute, what would happen if I dumped my health insurance? And I want you to just play along here, because I realize this is not optimal, but suppose I said, so my premium, and I cannot even believe I'm so dumb as to pay it, is I pay United Healthcare $1,400 a month just for me. Right? And I go to the doctor twice a year.
If you lost a little weight and were a little healthier about the way you lived your life.
I do have to worry about that. Yes, I get my ears cleaned out by my primary care physician. Why he's doing my ears, by the way, is beyond me. But twice a year. I maybe use, in real terms, maybe $200 of healthcare a year.
Right.
I'm paying them, what's 12 times 1,400, whatever that is.
It's $17,000.
$17,000 a year, and have been so doing for 20 years. Right? I paid hundreds of thousands of dollars into the system. By the way, we're not counting all my taxes, and I've used a fraction of that. So my first thought is, why am I such a sucker? What would happen if I said, no more, right? So the first question is, what happens if I get hit by a bus? But then so suppose they present me with the $600,000 healthcare bill. It's a phony. Can I have my attorney, David Goldhill, call up Mount Sinai and say, you guys got to be joking?
Well, you'd have to wait the time for me to go to law school past the bar.
That's right. But you went to law school.
No.
Okay, all right. Well,
No.
I'm scarcely going to have
a lot. I think that's where you're.
I'm scarcely going to have any trouble finding someone in New York.
You'll find a lawyer to take that
right?
case. Here's the problem.
Even if my condition is their last name is David, or Goldhill, and their first name is David.
We can find one.
We can find
one. Yeah. But back to your question. The problem with going rogue is that having real customers is a bad business model for our healthcare system. So it's done everything possible to suppress that, and there are some wonderful analyses of recent legislation, including the Affordable Care Act, which talks about what these really are industrial policy bills to maintain very high profit margins by preventing competition. Let's look at your real life example. The smart thing for you to do once you dropped health insurance would be to buy real health insurance. Buy I get hit by a bus insurance. You can buy it and everything else, right? You don't buy furniture going out of style insurance, but you do buy house getting hit by lightning insurance. Yeah. That product's not available. Nobody wants to actually underwrite real health insurance when you don't have to.
So let's talk. Hypothetically, what would real health insurance in my case, what would my deductible be? 25 grand?
It doesn't exist. But let's try to price it. All right.
Yeah.
So you're now spending, what did we say, $17,000 a year on health insurance. So if I said $25,000 deductible, you're likely to use that 1 or 2 years of your life, maybe 3. So I'm going to get 50, 60 years of premiums to cover that. Maybe we're looking at $100,000, $200,000, $300,000 of total exposure when you get hit by a bus those 3 years, or some of the other things that are major medical likely to happen to you, and we should come back to that. Mm-hmm. So you're probably looking for that policy somewhere in the $3,000, $4,000 a year insurance range. But you got a $25,000 deductible. On the other hand, you've just saved $13,000. You'll earn your deductible back in 2 years. So you probably don't want to buy that insurance. You want to buy $50,000 deductible insurance. What's different about our conversation is noticing we're saying, this is what you should want. We've just had 45 years in which the debate has gone the other way around. Protect me from ever having to write a check for anything. Right? My health insurance stinks because I have a $1,000 deductible. Or I have a copay. And the only way we do that is because we're ignoring the fact that we're putting, a family policy for my company this year will cost $24,000. Right? So only if you ignore that $24,000 has come out of your income do you think bearing a $50,000 deductible seems incredible. But you can't go rogue. Because the other part of being rogue is that the providers are set up to serve you. And they're not. Right? They're set up to serve intermediaries, what I call the surrogates, which is the insurers, Medicare and Medicaid. And they're very different customers than you are. They don't care about customer service. They don't really care about quality. They're okay with massive amounts of excess. And ultimately, they're okay with a lot of accidents. You're not going to be. And until there's enough of you, the providers won't change to deliver the type of care you want.
How hard is this transition to a kind of market-based system? So I have a dentist, and I go and see him, twice a year for my whatever. He takes very little insurance, as far as I can tell. Most people are paying out of pocket. Service is fantastic. The prices are real. It's not that expensive. Treats me like a king, right? And he's the same guy. He just happens to be a dentist and not a doctor. It's the same.
What's his name?
It's the same. So my point is, I don't see this transition. His reference point is not doctors. His reference point is the real marketplace.
So, it is interesting. So at the edges of healthcare, there are lots of competitive markets. Dentistry is one. Mm-hmm. LASIK surgery is another. Cosmetic surgery is another. Believe it or not, veterinary services are another, where a lot of the same technology, services, skills, equipment is used. And we can actually compare what happens in a market where the customer's writing the check and one in which they don't. There's a reason almost nobody ever waits to see a plastic surgeon in a waiting room.
Yeah.
Or a dentist for that matter. Or most optometrists.
I'm curious about vets. If we look at, does your dog get real prices?
So it's funny. There's a recent study that came out showing the comparative costs, and I don't want to get silly with this, but it is worth thinking about, of a hip replacement in a dog and in a person. Different hips. But what we would identify as costs in the real non-healthcare world, the time it takes, the equipment it requires, the room you need, obviously there are different regulations and standards, they're not that different. I mean, the technology is not that different. The doctor's pay is different, of course, but that's because one's in a competitive market, one isn't. I think the study said that the average price of a hip replacement in a human was something like 20 or 25 times that of a dog. And it's not because of cost, right? Now, there's greater value in replacing a hip in most humans than in most dogs.
I would have said the
know
opposite.
I shouldn't have said that.
No, not because I'm a dog person, but a human can very happily get around on a bad hip. All kinds of, but you can't put a dog in a wheelchair. And I mean, a dog actually needs his hips to be a dog.
I don't want to imply I've spent more time on this issue than I have.
Yeah.
I was really more getting at the technology of the operation.
Oh, I see. I'm sorry.
But there are obviously deeper issues involved, which we can think about. But the point was a different one, right? Which is what we think is happening in healthcare. What we think is happening is that we got Medicare and Medicaid pushing prices down, pushing prices close to cost. And what we don't understand is there's no such thing as cost. The bulk of it is how someone prices his time. And if you price your time in non-competitive markets, you price it higher than you do in competitive markets. And so, again, it's not to say that operating on a dog is operating on a person, but look at cosmetic surgery. They're both about operating on people. Mm-hmm. Cosmetic surgery is a very competitive market, except in the reimbursable portions of it. I had someone tell me a story today about going into her signing up in a rehab facility, and they said to her, it's so great to get new patients in January. We almost never get new patients in January. People haven't spent their deductibles yet. The point is it's distorting, right? And it's now so ingrained in the system we don't even think of it.
Yeah. So let's, as far as I understand it, your solution to a lot of these things is to kind of make it possible, make the institutional changes necessary for us all, in a way, to go rogue. So we say to Becky, right now the system's going to take $2.5 million away from you over the course of your life. What if I just gave you the $2.5 million, or in some version, and let you make your own arrangements for how you would like to prepare for these inevitable costs of healthcare?
Well, some of it. I mean, I think it's worth pointing out, I'm not saying there's nothing about healthcare that isn't special, right? What I'm saying is it's limited to what we know are catastrophic risks, which are things that are rare, major, and urgent, right? And unpredictable, I should say. I think that does need to be covered by insurance, the same way having your house burned down need to be covered by insurance. But every single person in this room is going to have major health care at some point in their time. That means just having health care can't be efficiently insured any more than if all of our houses were going to burn down, there is any efficient pool for sharing that risk. It's not a risk, it's a certainty. So what I want to do is stop thinking of healthcare as a single thing and recognize what's happened in the last 40 years. which is we've gone from most healthcare being rare, major, and unpredictable to everybody using a lot of care at all times, and some of us using and all of us using an extreme amount of care at limited times, and then a small percentage of the population, the very sick, needing a lot of care over their whole lifetime. And when you stop thinking about all healthcare as being the same, you say, well, wait a minute. Those people who have extreme healthcare issues, insurance probably makes sense because that's something you can be born with. There is no way to underwrite that sensibly and allow that to change it. And a lot of our dysfunction in insurance, a lot of the pain we suffer, is because for some reason insurance is a product that's not portable. It depends where you work, where you live, what school you go to. And so at every stage in life you get re-rated. But the part that should be insured is that luck part, that extreme part, right? Then there's another part which is major. There's a difference between getting very sick at 80 and getting very sick at 30. All of us are likely to get very sick in our 80s or 90s. That's really not an insurable event. It's just going to happen to everybody. Getting sick when you're 30 is different. That's insurable. The later part has got to be saved in the same way that as a society we save for the support and income of people who are older and retired. But we don't think of it that way. Of course, we've reversed that. We treat all health care of older people as insurable, which has created this flood of excess care, which is, frankly, an assault on their bodies, and essentially left the 30-year-old on her own in the sense that if she ever gets sick, she's going to be paying much higher insurance rates for the rest of her life. So that's opposite. The rest of health care, the rest of that $10,000, $20,000, $30,000 a year, you all are contributing into the system every single year. If it's returned to you, we'll create a more accountable healthcare system. One that does compete on price, one that does compete on quality, one that does compete on safety. I spend a lot of time in hospital safety issues. I'm on the board of Leapfrog, which is the major national hospital safety organization. You cannot imagine how careless our hospitals are. You cannot imagine how careless our entire healthcare system is. We would not tolerate it in any other industry. Anything, not a fraction of it. But because Medicare is the customer, and your insurer is the customer, it doesn't matter what we think, and that's got to change.
I'm going to make one last comment, and then we're going to go to questions. I think we can have fun with some. But I just wanted to very, very briefly walk through practically what it would mean. So we would say to Becky, we're going to give you a grant of X number of dollars every year, which will go into some tax-free account just for healthcare. With that money, let's say it's $5,000-6,000 a year. With that money, you can buy true health insurance with a really, really high deductible for when things go, for when you get hit by a bus or have, cancer at the age of 40, or right. Which might have, and then with the money that's left over is yours to spend as you see fit and to save for what you know to be the inevitable costs of your old age.
And I think that's where we want to get to. The question is, how do we get from here to there? The way we get from here to there, I think, is by basically recognizing that people of a certain age, it's probably 55 plus, have assumed they're going to get Medicare their whole life. And there's no way to transition economically them to any other system. Forgive me for not being appropriately partisan, but I actually confiscate the ideas of both the extreme left and extreme right and bring them together. I think we should have national health insurance. Cradle to grave, every American, you got to pay into it. I think it should be catastrophic and strictly limited to catastrophic. And I think in the exact opposite of what we do now, what that insurance should cover should decline over time. So in other words, we need an insurance system today because none of us have health savings. But we want every year for the amount of that insurance to decline. You do it by raising the deductible every year. What that will do is it will create lower insurance premiums every year. We want those lower insurance premiums to be saved. And what we want to do is build up health savings so that people feel security, catastrophic insurance so they know financially they are protected. And here's the other wrinkle, and it's the Singapore wrinkle. We always want you to be the customer. Your catastrophic insurance has got to be a way for you to pay for care, not someone to negotiate care for you. One of the craziest things in our political discussion is this assumption that private insurers are going to drive down prices. There is no way for their returns on capital and for their profits to grow if the amount spent on healthcare declines. I mean, it's the most obvious thing on earth, and there's not a single politician, as far as I can tell, who understands it.
Yeah.
Right? Your insurer may always say no to you, and in fact, they now always say no to you, regardless of, we presented a claim for my son's ruptured appendix. The letter we got back saying we're not sure surgery was the correct response. They do that just to make you fight, right? Because that's a hidden cost of insurance. You got to fight for even obvious reimbursement. Insurance is a financial tool. Having insurers be the customer of the economy of the healthcare economy has been a catastrophe for us. So that's where I want to get to. And what it's about, and we're not going to do this tomorrow, the Affordable Care Act's going to have to fail first. But what we're going to do eventually, I think, and what countries around the world are starting to do is say, you know what, true accountability always seems to work better in a disaggregated form. Chasing customers tends to make institutions more accountable than trying to convince a regulator to let me do this, let me price this, by the way, protect my market while you're at it. Healthcare is incredibly complex, right? We talk about healthcare, it's thousands of goods and services. It's just too dynamic, too ever-changing to work in anything else other than that. So what I'm trying to do with all of this, it's not just financial engineering for its own sake, is to restore us to the customer. Because that's the only way we can be passive enough to get great health care. Only customers can be passive. As we all know in our insurance system, we got to fight like crazy for attention, for service, and ultimately for reimbursement.
Well, thank you, David. And now we have time to take questions. You're asking if the consumer is going to shop around and choose their own MRI. That's a very complex decision. Quality of the MRI is enormously variable, as is the quality of the person reading it. And is that a lot to ask of a consumer?
Of course. Consumers aren't going to do that. And that's not how consumer-driven economies work, right? You can't explain, well, maybe you can, I don't know you, but you can't explain most of the ways this works, right? So 50 years ago, there were several hundred of these on Earth. There were a couple thousand people who knew how to use them. What happened isn't that 6 billion of us got educations in computer science. What happened is someone got paid for making this simple. So that the average person in the room can compare this to a BlackBerry and an iPhone and a non-smartphone and a landline. Someone made money by making that simple. The system we have now has nobody doing that. So I agree with you completely. All MRIs are not the same. But you have zero information about that in our current system. None. Just because someone charged you $1,200 doesn't mean it was better than the $300 MRI. You have no way of knowing that. You know nothing. I guarantee you there's nobody in this audience who knows which hospitals in New York City are the most dangerous. But there are significantly, maybe a couple of you do, but there are significantly dangerous hospitals and you don't know it. And what I'm saying to you is you will know what the most dangerous hospital in New York City is when you see a billboard that says, have your surgery at Uptown because downtown will kill you. That's the same thing that'll happen in MRIs. It's so much a part of the rest of our lives, we don't even think about it. And I'll tell you, it's the greatest criticism of consumer-driven healthcare on the island. The island says, you can't expect consumers to do all this work. What are we doing now? Your health insurer call you up and say, yeah, I'm concerned about that spot above your eye. I'd like to see you have that checked out. That's not how the system works. The way the system works is your kid has a ruptured appendix. It takes you 7 or 8 forms to get surgery. He waits for hours and hours in pain. You get an incomprehensible bill, and your guy says, I don't think it's medically necessary. That is the system we're comparing it to. Not a system in which somebody, government or insurer, put their arm around you and said, I'll take care of this. Don't you worry. I don't know if everyone heard the question, but the gentleman asked about, he has 2 daughters, one who lives here and one who lives in Prague. And you said the one in Prague is just is happier and more fulfilled, or no? You said that she had better health care. I'm sorry. And she has better health care and probably a lot cheaper too. And so I'm glad you raised that question because it's a question that comes up a lot, which is why do the Western European countries and our friends in Canada, why do they deliver the same or better health care results for less money? And wouldn't it be simpler for us just to do what they do? I think it's just a great question. And clearly one of the things I'm saying that I think is most controversial is no. But let me explain why. I think there's a couple big reasons and a lot of small ones. One is that all of these systems are facing rapid increase in costs, just slower than ours, right? I sometimes say, the United States has fallen off a cliff and is near the floor. These other countries have fallen off a cliff, but they're near the top of the cliff. They look better than we do. But if you look at most healthcare systems around the world and you look at the debates in those countries, including in Canada, the debate is how can we afford healthcare? The Canadians are up near 12% of GDP. A number of provinces are near 50% of government spending on healthcare. But it's a better system for today. And the why of that, I think, is important. The reason these systems achieve what they achieve at lower cost is because they put explicit budgets on things. In Medicare and Medicaid, we've made the statement, we will pay for whatever people need. And so the industry responded by saying, you need more and more, right? This population gets healthier and healthier every year, and people need more and more healthcare. Well, of course, because it's not about need, it's about want and preference and lifestyle issues and all the rest. But they've effectively defined need greater and greater as any industry. Believe me, if you told people we'll give you as much cable television as you need, we would be defining need more broadly. And that's just a natural industrial response. That's what we see here. No other country on earth does that, right? So what looks generous is, in fact, an invitation to waste. But that invitation to waste, I think, tells us something important about the US, which is we have a hard time hearing no from politicians, and politicians have an incredibly hard time saying no. So if you want to import what's worked in these other systems, what's worked in these other systems is they have budgets, and you can't go over them. And so you don't get more care. I think, the bigger issue, and so I don't think it's going to work here for a lot of reasons, but I think that's the biggest one. I think you also have an issue here that you don't have in many of these other places, which is no real tradition of a government regulatory body that can deliver a service. And what you see in Medicare is extraordinary industry capture. I mean, one could look at CMS as being run for and by the hospitals, and you'd be a lot closer to understanding their policies than anything else. It's an enormous risk if you turn over all of healthcare to them. So I think that's a risk. I want to add one other point. I think those systems are fundamentally backward looking. I think they're about taking that firefighting model. You're sick, you need help, you can't afford it, we'll pay for it, and applying it to an industry that's changing in front of our eyes. The fat part of the growth bat in healthcare is about things that used to be lifestyle that we now have found medical ways, not even to treat, but to manage, to help, to assist. And that's just not going to work in an insurance model no matter where you have it.
If I might interject with a question. I remember having a conversation with a guy who, one of the founders of the KIPP charter schools, and he was talking about why they were spending so much time and energy opening charter schools in Houston. And he said, well, the reason is that if we open enough of them, we'll collapse the public school system. So in other words, instead of trying to solve the many problems of the public school system in Houston, he said, no, let's just have an alternate model. And if we can be better over time, people will just stop going to the public school system. And I'm curious about, with the Goldhill plan, why do we actually need to solve the problems with the current system? Why can't we just set up an alternate plan B that I can opt into? And if it turns out to be better, then we'll collapse the system on its own. Do you know what I'm saying?
I do, and I think, look, there's a critical mass. I mean, that was my point about preventive care. Enough people were paying for their preventive care out of pocket that we were starting to see a competitive market develop in preventive care. Mm-hmm. I think the important thing about healthcare is that there doesn't need to be one healthcare system because there's not one such thing as healthcare. Yeah. And so it is a matter of critical mass. I think, I think one of the accidental consequences of the ACA will be very few companies. This is probably 5 or 10 years from now, but very few companies will offer standard health insurance policies like they look today, right? It'll almost be financially impossible to do so for a variety of reasons. And I think what you'll see happening is companies start to invest in health insurance, real health insurance, with large deductibles. And I think it could be large enough so that you'll see a marketplace develop alongside. And it'll be a great test because it'll be, look, we're already starting to see that with concierge care. The very rich and, interestingly, the very poor have cash markets developing in healthcare because they don't want to be, the doctors that can attract the richest patients won't take health insurance. They don't want to be bothered with if you go to a doctor's office, there's 3 clerks for every physician. They don't want to be in that business. And interestingly, if you go to communities where there are lots of illegal immigrants, you see the exact same thing happening at the lower end. I don't take health insurance. I only take cash. I know you can't pay a lot. That's how physicians work in illegal immigrant communities. And so I think we may, particularly if the Affordable Care Act drives health insurance out of the affordability for the non-subsidized, which I think is a real possibility, we might see that. Look, Herbstein famously said, unsustainable trends end. And this growth rate is unsustainable. You can't really ask Becky to pay $2.5 million.
Don't you love how it's called the Affordable Health Care Act? It's like like calling that big thing downtown the Freedom Tower. It's like freedom from. Well,
I know a lot of people feel very
freedom from market forces towers. I like to call it.
But a lot of people feel very passionately about the Affordable Care Act because they think it achieved something that was just.
Yeah.
And which was to include everyone in the system.
Oh, it's certainly just. It's just not affordable. It should be called the Just Health Care Act.
Well, I don't even think it's just because I think what's happening, it's very hard to get prices even for what Medicare and Medicaid pay. But for most procedures, Medicaid pays about half or less of what private insurance pays. Medicare pays 2/3. So what most health economists say is, Medicare is driving lower prices, Medicaid's driving the lowest prices. And I don't think that's what's happening at all. Any more than the fact that McDonald's offers a cheeseburger for 99 cents and DB offers one for $32 tells you that McDonald's just does a better job of serving value. They're serving a different product. Yeah. And I think Medicaid, Medicare, and private insurance are delivering different types of healthcare experiences for their beneficiaries and clients, and we've missed that. So driving more people into Medicaid, I'm not sure is going to wind up being just. I'm not sure many of them weren't better off in the cash economy.
Yeah.
So the question was, when you compare what we spend on healthcare to what other countries spend on healthcare, it looks roughly the same until you get to Medicare age. And then Americans who are Medicare beneficiaries, or 65 or older, which are almost entirely Medicare beneficiaries, spend far more than other nations. What does that mean? What does it say about Medicare? So I think the story of Medicare is one of the great misunderstood stories in American politics today. We argue over how much Medicare can we afford for our seniors. And our seniors are out there through their organizations lobbying for as much Medicare as possible. So 1 out of every 3 seniors will have surgery in the year of their death. 1 out of every 5 90-year-olds has surgery in the year of their death. What Medicare has done for seniors is turn them into the crash test dummies of the healthcare system. It doesn't mean all the care they receive is bad. It just means that when you say, we'll pay for any care that people need, you've changed the balance of the discussion between doctor and patient.
Any care that people need at the end of their life.
Well, yeah. Period. I mean,
yeah.
The amount of health care seniors receive cannot possibly be good for them, right? 40% of 75-year-olds and older are on 5 or more prescription drugs. You should understand that we talk about surgery for seniors as if it's just something they should have, hip replacements, spinal fusions. The health consequences of surgery, forget about money. Just don't even think about money. The health consequences of surgery, that balance between risk and reward for a senior, is far more precarious than for a non-senior. Never taken into consideration. There are books and books and books. Overtreatment is a great one. Rethinking Aging is another one. About how what our healthcare system has done is it's turned all our seniors into patients without taking that risk-reward into consideration. I'll give you just a silly little story. This friend of mine told me her grandfather was depressed, 90 years old, because his physician had ordered him to stop his nightly glass of scotch, what he's been doing since he could start drinking. And he did it because the scotch interfered with some anti-Alzheimer's medication he was taking that we have no idea if it works. Nobody in that family ever thought, you know what? Is it worth it? Is it worth it? Is what we're doing to our seniors worth it? When Don Berwick left as head of CMS, he said 25% of all healthcare spending was waste. It's not money that's being wasted. All of those procedures have side effects. Every single one of them. Even the tests have side effects. And what we've done with our seniors is we've said, good news, you never have to think about money. And what the doctor says is, I think you need a spinal fusion. You may be 65, you may not get a lot of benefit. People 50 don't get much benefit. 1/3 of bypasses that are recommended are considered unnecessary by cardiologists on standards. And you can go on and on. We can spend all night talking about it. But what's interesting is it's never discussed. Nobody ever says, is Medicare good for seniors? We like the idea of helping seniors pay their bills, but what have we exposed them to in terms of the incentives we've given the providers to treat them? The question was that implicit in a lot of what I was saying is that we have an overconfidence in healthcare procedures and in their ability to work and to solve our issues. What accounts for that overconfidence, and I guess what do we do about it? One of the, in the midst of one of my long-winded answers, I forgot an aside I was about to say, which is one of the tricks in healthcare is to say, how come France can achieve better outcomes than the US on only 12% of GDP? The trick there is there's almost no difference in health outcomes because we don't measure them. The difference is in the big statistics in healthcare, which is life expectancy, infant mortality, and a few others, almost entirely relate to income, lifestyle, education, happiness, taking vacations. No politician's going to stand up and say, because I want Americans to live longer, I'm going to insist we spend less money on healthcare and we all take more vacations. But in fact, it would work. But we don't want to believe that, right? And when we're not feeling well, seeing a doctor makes us feel better even if the doctor does nothing. And, we talked a lot about money and sort of rationalism and all the rest. We're never going to be rational about healthcare. We're not rational about anything, right? And one of the reasons we set up a system where we're the customers is to have people chase us with our irrational needs and desires and compete against each other to serve them. We're always going to want and expect more from healthcare than we're going to get. But I think we've taken it to the point where it's a major illness that explains why we're going to spend 20% of GDP on healthcare, and we've got almost nothing left for welfare. We've got almost nothing left for the environment. We've got almost nothing left for recreation. We've got almost nothing left for the things that actually drive health. We're spending it all on healthcare, which has almost no impact on health on a society basis, no matter what we may think as individuals.
Thank you very much, David.
Thank you, Malcolm.
Thank you all.
Thanks for coming. Thanks for coming.